I think we're going to go ahead and start. We are expecting a few more people to trickle in, like maybe 3. But since we have a lot to cover and it's going to be a packed day, we thought we'd go ahead and get started. So for those of you who don't know me, which is probably most all of you, I'm Lisa Cooper, and I'm one of the co-principal investigators of the Rich Life Project. And in the back of the room is Jill Marsteller. She is the other co-principal investigator of the Rich Life study. So we just want to welcome you and thank you so much for coming on such a rainy, dreary morning, and for actually coming on, I know, rather short notice. For many of you, you learned about this last week, right? But we hope that this is going to be a really enjoyable and beneficial experience for you and for the patients that you take care of. We're really excited to have you as part of our team, and we also welcome any input and feedback from you about what we've developed, as well as the training program. And you know, we know that you've had years and years of wisdom and experience in working with the populations that we're seeking to serve and to improve care for. So just thank you again. So this session is going to be an overview of the Rich Life Project. And what we're going to do is to just start out with brief introductions. Many of you may know each other already, but for those of you who don't, you can get a chance to introduce yourselves to each other. We're then going to just give you an overview of what the training will look like over the next 10 days or so, not including the Memorial Day holiday. We'll talk a little bit about care teams and their role in managing patients with chronic disease. And then we'll talk specifically about the roles of care managers and community health workers and responsibilities that are part of the Rich Life Project. And I think you'll find that they're familiar to you. They're things that you are involved in already, but in some cases there may be more structure or guidance around managing specific conditions that patients have or specific situations in which they find themselves. Okay? So first I'll introduce and tell you about members of our research team, and then we will introduce you, or have you introduce yourself. So first of all, I guess we're having trouble bringing the slide down to so where you can see, but the 2 principal investigators of the Rich Life Project are Dr. Marsteller and myself. We have several work group leaders, and you know, I'm not going to read through all of the names just in the interest of time, but I will mention that Carmen Alvarez is one of the co-leads of this collaborative care work group, and so you'll be seeing her during the training program. And there should be a directory of study team members in your binders, and so you'll be able to look through your binder and learn more about each of these people. So Carmen Alvarez, you'll probably be seeing a lot of these folks throughout the training program, but in particular, I think you may have the chance to interact with Carmen Alvarez. Another person so we have several work group leaders, and we'll go through and tell you more about what different people do, but I think for the most part today we want to spend a lot of time talking about you and your role and the project overall, and then if you have questions about how the other interventions interface with you, then we'd be happy to take those questions. So the other than the work group leaders, so we have several work groups that deal with the collaborative care intervention, which is what you're involved with the community health worker intervention, with blood pressure measurement, with the health system aspect of the study, with the dashboard, so other things. So then we have other faculty who are, for the most part, who you see listed are experts in different areas, specialists for different conditions that are commonly seen with hypertension, as well as people who are experts in things like medication adherence, blood pressure measurement, that kind of thing. Then we have our project managers who actually really help to make this project run. Well, you know what, so I'm sorry, I like skipped over Dr. Chidima Ibe, who I'm sure many of you have heard from already and met with. And she is our lead investigator on the community health worker intervention work group, as well as our stakeholder engagement manager for the center. So we also have a lot of project managers. Two who aren't here right now, who you'll get to meet, are Katie Dietz and Jennifer Halbert. And then we have just wonderful, wonderful project staff, some of whom you've met already. Grace Bigelow, who helped to make sure everything, all the logistics were arranged for this program. We have Mackenzie Eakin, who isn't here right now, but you will see at some point. We have Ariel Hicks, who's behind the camera there. We have Dasam Jang, who isn't here right now, but you'll probably see her when you learn more about documentation in REDCap. And we have Joe Landavaso, who's in the back room, who is extraordinaire blood pressure measurement trainer, just basically all around, like our right-hand man. And then we have Erica McCannon, who was here earlier, but I don't see her in the room right now, so she must have stepped up.
Erica was the lovely young woman you saw when you came in with the blonde hair. She's very helpful. Yeah,
Here she comes. Here's Erica. So anyway, so we got a great team, and then we have you, many of you, I put your names up, but what I'd like to do is just have you introduce yourselves. Maybe what we can do is go around the room, and then I know everyone that we were expecting from Johns Hopkins Healthcare, JHCP, was able to make it except for Shamika Franklin, I believe. And then we have the team from Total Healthcare, who we only have one person here right now. So why don't we just go around and you can tell us who you are and just tell us what role you are working in and what site you're from, maybe. Do you want to start with Lauren?
Yeah.
Okay.
So I'm Lauren Phillips. I'm a community health worker, and I am at Green Spring, White Marsh, and Belkia.
Hi, good morning, everyone. I'm Mary Krob. I'm a community health worker as well. I service Montgomery County and Prince George's County and a little bit of everywhere else in the state wherever they need help. So it's great to finally see faces and names, and it's a wonderful way to start the Monday, so thank you.
Good morning, I'm Suzanne Harrison, and I'm going to be a case manager. I'm a recent transfer to Johns Hopkins Healthcare from Johns Hopkins Hospital, where I was a outpatient case manager for cardiology. So this fits right in my bailiwick. And I'll be out of Bowie.
Okay. All right, and then we have Helen, which your Total Healthcare slide is the next slide, but go ahead and introduce yourself.
Hi, my name is Helen Owanda. I'm a community health worker at Total Healthcare. I work out of the division site.
Hi, I'm Teresa Messer. I'm a case manager at Hagerstown, and I'm the team lead for Region 1.
Hi, I'm Cheryl Sprague. I'm a nurse case manager, and I work out of JHCP at Water's Edge.
Hi, I'm Gloria Whitten. I'm a case manager. I'll be working with the Fulton office, and I'm all over the place with Region 1 to Pennsylvania.
Hi, I'm Stella Marine. I'm a case manager, and I'll be covering Dundalk sometimes, but I'll be Region 3. I'm Region 3 case manager, but I'll be covering Dundalk sometimes.
Tracy Harris. I'm also a transfer from the home care group, but I'm going to be a case manager at Dundalk. I guess she and I will share the responsibility, and I'm learning from her right now. So there are.
I didn't quite get your name.
I'm Tracy.
Tracy.
Yes.
And let's see, back row.
Hi, my name is Raymond Randolph, and I service the Arundel County area.
Where, sorry?
Arundel County.
Arundel. And we have Dr. Delbert.
Good morning, I'm Bradley Oliver, community health worker supervisor, and I supervise CHWs across the state.
Anybody Anybody else? Did I miss anyone? Okay. All right, it's wonderful. We look forward to getting to know each of you more. And so this is our total healthcare team, which Helen is representing right now, and we hope we'll see Danielle and Vanessa and Dorothea at some point today. So we'll start out just letting you know who all of our health system partners are for the Rich Life Project. They are Johns Hopkins Healthcare and Johns Hopkins Community Physicians. We also have Total Healthcare, and you guys are part of what we're calling the first group of practices that are going to get, you know, the interventions. So starting in July, we'll have a second group of practices that will join the project. So the next group will include community health workers and care managers from Choptank Community Health, which is in southern Maryland, Family Health Centers of Baltimore, Park West Health System, and Berks Community Health Center, which is in Reading, Pennsylvania. So we have this group is representing 16 practices, and then the next group is going to represent 14 practices for a total of 30 practices that will be involved in the project. So we're funded by the National Heart, Lung, and Blood Institute through our program that's called the Hypertension Disparities Reduction Partnership. And we also got funding for this project through the Patient-Centered Outcomes Research Institute, which is also called PCORI. And so the other people that are involved in this project are the National Institute of Neurologic Disorders and Stroke. There's a company, a data research company called Westat in Montgomery County that's also a partner with us. And we are representing the Johns Hopkins School of Medicine as well as the Bloomberg School of Public Health. And then we have a group of colleagues from the University of Alabama in Birmingham that are, actually it's also the University of North Carolina at Chapel Hill. It's like a large project that's based in the Southeast, so it'll cover many practices in North Carolina and in Alabama. And they're doing a project that is similar to what we're doing, but they're going to do something a little bit different. But the idea is through these two projects, we are to learn a lot more about how to care for underserved groups with uncontrolled hypertension in this area of the country, which is the Mid-Atlantic, and then also across the Southeast. So we're representing more of an urban and suburban population, although we have a few practices that are more rural, and then they're representing more of a rural population. So these are our community partners here in Maryland and Pennsylvania. We have a lot of community partners that are part of this project. I'm not going to list all of them, but they represent insurers. So you can see Priority Partners up there. They represent community-based organizations such as Sisters Together and Reaching, which also trains community health workers. We also have professional organizations that are part of the group, such as the American College of Physicians, the Association of Black Cardiologists. We have business partners like Omron, who makes the blood pressure measurement devices for patients as well as for clinics. We have just lots of partners that are involved in this, and the idea behind this is that this project is to engage everyone who is involved or who has some stake in the game for getting blood pressure under control in these communities, and have us work together so that what we learn from this project will be something that everyone can use, patients, family members, as well as people in these organizations, so that we can actually move this work beyond being a research study into like actual system change and community change. So the other thing is that we have public health partners as well, and we have people who are involved in policy, so city government and on the state level, congressmen and state representatives and things like that. On the federal level too, actually, Congressman Cummings is a member of his team is a member of our community advisory board. So this is, the way that we engage the stakeholders is that we have quarterly meetings with our advisory board, which is, like I mentioned, about over 30 people who represent these different groups. They guide our research all the way from the planning into the intervention and the evaluation as well as the dissemination phase. And so Johns Hopkins Healthcare and Total Healthcare and JHCP have really been all involved in the planning for this project. We place a high priority on relationships, and so our principles include respect for diverse perspectives, so we welcome different perspectives. We believe in partnership in decision making, so we're not an authoritative group where we come in and say, you guys are going to do this. We think we should all be involved in the decisions related to the project. Clear communication is something that we really value, so if at any time you feel like you're not understanding your role in the project or where the project is going or anything confusing, please let us know, because we really aim, to make sure that we are informing you, keeping you up to date, that we hear from you about any issues or concerns you have. Trustworthiness is important, so we will do our utmost to be completely transparent about what we are aiming to do or any challenges we're facing, and things that we may need to address, so that you can understand our perspective, and we know that that's really important in order for us to gain your trust. The other thing we aim for is concordance in values. So it's important to all of us, I think, to have meaning in the work that we're doing, and we can't always agree on everything, but there are certain values I think that we might share, and that is what makes us work more effectively together. So, as we go through this week, I'm sure we'll learn more about you and the things that are important to you and why you do the work you're doing. And we want to be able to support you in doing that work, and in that we can all, do a better job and hopefully help to accomplish the goals that we want to accomplish, because we know that these problems we deal with are very tough. So here's the overview of the training today. We are going to have welcome and orientation for the most part today. Day 2 is going to be your training in patient-centered communication through motivational interviewing, and how many people are actually able to go to participate in that training? Okay, wonderful. So the state of Maryland has an organization called the Maryland Health Education Initiative, and they provide that training. And I know many of you have had motivational interviewing training before. Is that how many people have had that previously? So pretty much everyone, but it's always a good idea to have ongoing training and refreshers, and because as you know, it's not, motivational interviewing is not something you just read about or you talk about one time. It's something that you keep working on, right? So then day 3, we're going to talk about the protocols and procedures and resources for this project. Day 4 and day 5, we're going to have overviews of the disease conditions that are going to be addressed in the project. For many of you, it'll be a review or a refresher, but we're going to really have experts, available to answer a lot of your questions, and if you have any issues that you've come up with in your practice that you would like to bring up during those times, we really encourage you to do that. Then day 6 is focused on partnering with patients. So we're going to be talking a lot then about communication with patients, and we're going to be talking about addressing issues like barriers to care and adherence to the treatment regimen. And then day 7 is then putting it into work. So we'll have a series of case studies that we'll be discussing, where we present the case, and then you all will talk about how you would manage that particular patient and what kinds of challenges you see and how you might try to overcome them. And then the same thing on day 9, we're going to focus a lot on the communication among team members, between the care managers and the community health workers, how you guys are going to interact with each other, how you'll interact with the primary care team, and how you will interact with us, with our research team. And then day 10 is just sort of putting it all together. And I know a lot of people can't come in person every day. We thought the first 2 days were very important, and the interviewing skills, days we think are particularly important to be there in person for. Some of the other sessions are more like lectures, and there are a lot of materials that you can read. So if you're unable to come because of prior commitments, we understand that. But we really encourage you to review the materials and to ask questions, because there may be some things that might be new to you that you didn't, cover previously, so, okay? So, let's see, so we're talking about your roles here. So, your role in this project is very crucial to the success of the intervention as well as the overall project. That is one of the reasons we took as much time preparing this training program, because we know that without you, basically the whole project kind of falls apart. So you guys are really like the foundation of this program, because you're the face of this project with the patients, especially with the patients in the clinics that are getting this program. So, we're going to be talking about, like I mentioned, the things, clinical considerations, as well as operational issues. And, we'll try to address that as much as possible. Of course, we're going to have ongoing contact with you, so that as issues come up that we haven't addressed during the training, we'll be able to address those. So, I'm just putting this up to make the point that, we deal with what we call disparities in health and in healthcare. And one of the primary goal of our center, which is a Johns Hopkins Center for Health Equity, is to address these preventable differences in health that different groups and different sectors in society experience. And so, there's been like lots of focus on this recently, but we know that everyone in our society definitely doesn't experience the same level of health or opportunities to be healthy. So these are numerous conditions that are affected that contribute to health disparities. I think it's ironic that the heart disease is not showing, because that's the one that's on the top of the slide, but that is actually, cardiovascular disease is the #1 contributor to preventable differences in quality of life and in life expectancy in our country and in the world, really. So you'll be hearing more about disparities in care later from Dr. Deidre Cruz. And then disparities in hypertension is the area that we really focus on. And again, I mentioned that cardiovascular disease is the largest contributor to excess mortality, and that even despite higher levels of awareness and treatment among certain groups, such as African Americans, they still have lower levels of hypertension controlled in other groups. We also know that persons with low income and people living in rural areas are disproportionately affected by hypertension and other cardiovascular risk factors, and they also experience less access and poor quality of care when they get into care. So that's one of the goals of this project, is to enhance the quality of care, the experiences of care, and the access for those groups. I didn't mention here Latinos, but that is another group that we're going to be also focusing on to a large degree in this project. So I'm going to start telling you about the Rich Life Project. And Rich Life stands for Reducing Inequities in Care of Hypertension, Lifestyle Improvement for Everyone. And so it took us a while to come up with this, but we got a lot of input from the community members and all the other stakeholders, health system, in creating the name of this project. It's really important to us that the name captures what it is we're aiming for. And so we really want to improve life experiences for everyone. So that was the team that came to the kickoff meeting, and we didn't have a lot of care managers or community health workers identified at that time. So we have a lot of the health system leaders are in that photograph, and some of our community advisory board members and our research team. So we had that kickoff meeting last September, and then the project launched. And the project basically launched initially with training of staff in the clinics. And I'll tell you more about that component of the study, which doesn't really involve you directly, but you'll notice that there are other things going on in the practices where you're working that are related to the Rich Life Project. So what are the specific aims of the project? So we're conducting, it's a clinical trial, but we're calling it pragmatic because it's like a real world study. It's not one of these things where you're sitting in an office, like somewhere in, I don't know, somewhere like not in a clinic or in a community, but in like an office building, and you're having people who volunteer to come to you and you're doing everything to them there. This study is taking place in the real world where people are living, where they're coming into there to get health care, where they are. So it's a pragmatic trial. And we're testing 2 different approaches to care for underserved and at-risk population. So one of them is the group that you're in, which is the collaborative care, stepped care group, and then the other group is what we're calling standard of care plus. So it's basically standard of care, but we're enhancing it slightly by offering certain things to the practices. So we're going to compare those 2 approaches to see which one actually is better at improving blood pressure control, and then we also have a number of other conditions that we're going to be addressing. And which one actually results in reduced disparities. So, you know, we don't have huge differences in certain groups of people benefiting versus others. And at the same time, we want to raise everyone to improve blood pressure control for everyone. So the other thing we want to do is to make sure that this approach is something that can be sustained after the project, the official project ends. It can actually be continued once the project's over in the clinics, and that we can then scale it, meaning that it can be taken and like used in other practices throughout the system or throughout the state, or even throughout, you know, the country. So again, it's a cluster randomized trial, and you know, if this is your introduction to research, I know how many people have been involved in research before? Okay, all right. So we've got a few. So what we mean when we say cluster randomized, meaning it means that there's instead of randomizing like individual patients, what we're doing is randomly assigning the practices to be in one group or another group of the study, right? So, then all the patients who are attending that practice are in that cluster. So what we're going to have is, like I said, 30 practices across Maryland and Pennsylvania, and 15 of them are going to get randomly assigned, or already have been actually, to what we call standard of care plus. And then the other 15, which are the ones that you are a part of, are going to be in the collaborative care, stepped care group. And then the main outcomes that we're looking for over time, we're going to be looking at blood pressure control and the average systolic blood pressure for the patients in the study over 24 months. We're also going to be measuring outcomes from patients, so we're going to be calling them at home and doing interviews with them on the phone and asking them questions about how they feel about managing their health and about the care they've gotten. So patient activation is a very important measure of how engaged people are in taking care of their health. So that's the main patient-reported outcomes. We're also going to be looking at health-related quality of life and different chronic disease self-management behaviors. So things like how often people are measuring their blood pressure at home, how often they're checking their blood sugars, how often they are taking their medications as prescribed, whether they're engaged in physical activity and how often, and things like what they're eating in terms of their, their diet. So we're also going to be measuring in this group, the group of patients that you're caring for, when they set a goal for something they want to achieve, to what extent are they able to attain that goal over the course of the study. Okay. And then they're also going to answer questions about what their experiences were in dealing with the care at their practice, as well as the care from you. All right, so this is these are the eligibility criteria for the study, and we've got a nice colorful brochure there that we hope people will actually look at when we mail it to them. A lot of people got it in the mail. We did a kind of a test of the project at Frederick. Did somebody say they were from Frederick here today? No. But anyway, we did this at the Frederick site. Oh yeah, that's right, Frederick is in the other group. So Frederick is actually in the standard of care plus group. But when we did the test with just 20 patients or so, we sent brochures out, and some of the patients like, recycled their brochures, so we actually had to mail them another one, but anyway, they were pretty, engaging and willing to participate once we reached them on the phone. Basically, we're looking for adults, so the patients need to be 21 years or older, they can be any gender. We're studying non-Hispanic whites, non-Hispanic African Americans, and Hispanic patients. We're not studying Asian patients and, a lot of patients of other ethnic groups because we don't actually have large enough numbers at many of these places where we could actually get a meaningful understanding of how we were doing with those. Also, those groups are not the ones that have high rates of uncontrolled hypertension. So these patients have to have a diagnosis of hypertension on their most recent clinic visit, and they have to have at least one other cardiovascular disease risk factor. So in addition to uncontrolled hypertension, they have to have diabetes, coronary heart disease, hyperlipidemia, depression, or be a current tobacco smoker. And you don't have to worry about finding patients because we will identify these patients from the electronic medical record and we will send the mailings to them. And we've gotten approval from the IRB and from your organizations to reach out to those patients and tell them about the project. So you don't have to worry about that, but you will, once they get recruited into the study and complete their baseline interview, then the interviewer is going to then connect them to you, okay, to set up an appointment to meet with them. So this is the way it goes, the recruitment piece goes, and I'm really sorry you can't see the top of the slide, but the top basically says we're going to review the electronic medical record. Then the study team is going to mail the patient their study packet, and then after that, the patient may decide that they don't want to be a part of the study. They might send a refusal postcard, that's in purple there, and they may mail that back to us, in which case we will not contact them any further. We will log them as a refusal. If you say, go over to the side where you see the green boxes, if the patient calls us to say that they're interested in participating, or if they don't send us a refusal card, then we will call them and then conduct a screening over the phone to make sure that they are eligible to participate. If they're ineligible, then we will not contact them any further. And this is unusual, but sometimes we will get something from the electronic medical record and we'll call the patient to verify it, and they'll say, I don't have hypertension, or, I have hypertension, but I don't have any of these other things. Or they might say, I don't go to that clinic anymore, I'm planning to move in the next 6 months, so there are things that would make us not include them in the project. So if they're eligible, they will do an oral consent over the phone, and then if they say no, at that point, they're out of the study again in red, but if they say yes, then we'll enroll them. And again, the standard of care plus clinics those patients will get care as usual. So we'll just call them every 6 months. And then in the stepped care, collaborative care clinics, which is where you guys are, the interviewer will then contact you. And we're going to go into a lot more detail with this later in the training, that how this is going to happen and how you'll be able to get that information and then subsequently reach out to the patient and make an appointment for them. And this will be the care managers who will be doing this. And you may be working with the front office staff and doing some of this scheduling. It sort of depends on where your practice is and how they handle this, whether you do your own scheduling or whether they assist you in doing that. So this is the timeline for the project. It's a bit overwhelming, so you don't have to read all of it. The point is that where it says intervention active in clinic, you can all take a deep breath because we're not going to start on June 1st. We would have liked to start on June 1st, but it looks like we're more than likely going to be starting around July the 1st, because we're going to need time after your training is done to get the information from the electronic medical records and identify people and then call them and then schedule them and all of that. So we're aiming to start around July 1st in the clinic. And then you can see that we'll go into the whole component of where the care managers get involved and then where they bring in the community health workers, or they reach out to other parts of the team, the specialists as needed. Okay? But the point is that we're gonna continue to see patients and interview them over the phone for up to 2 years after they start. You're gonna hear a lot more about this, but if patients get their blood pressure under control or they reach their goals and they say, you know what, I'm doing fine, we have a whole, protocol around what you do so that you don't actually end up you don't have to like talk to people every week if they're doing great and everything has been attained. But we know that people sort of have things, they do well for a period of time and then something else comes up. So we will have procedures in place whereby you will periodically check in to make sure that they're still doing okay. So this is the rollout plan, and I already talked about how we're gonna assign half of the clinics, the ones in green, to Standard of Care Plus, and then half of the practices to the Collaborative Care Step Care group. And then what's going to happen is that for each clinic, we're going to enroll 63 patients. So each of you would be responsible for managing that caseload of 63 patients. Now, they're not all gonna come on day one. So it's probably gonna be something that is a gradual roll out or ramp up. And then, some people are gonna be doing better and you're not gonna be dealing with, we don't think you'll be dealing with 63 people all the time for the next 2 years, But that's the goal. 63 patients per clinic for a total of 1,890 patients over the entire project. And about 945 will be in this group of the study, getting care management, community health workers. So we already talked about the primary outcomes, which we're gonna measure those from the electronic medical record and from the patient interviews. So we are going to talk about the interventions now. And and if you have any questions, clarification questions, I'm happy to take them. Okay, 2 questions.
That was one of my questions. Should we save questions for the end, or as you go along, would you like us to ask them?
So I would say, how should we manage that? I think if it's a quick question of clarification, I can take it like now. If you think it's something that's going to involve more in-depth discussion, or if I think so, then I'll address it again at the end. How about that?
Okay, I had a couple questions I've been saving. So the insurance, it does not matter. This is all insurances are included?
Yes.
Okay.
Mm-hmm.
And is a patient ineligible if they're already in case management?
Yes.
So
they are. If they're in case management for hypertension already, they are not going to be in the project.
Okay. And then you mentioned 2 years. I noticed in the material we had, it said something about us to November. So are we involved for the 2 years?
Yes, you are involved until those patients attain their goal of the study. Yeah.
Thank you very much.
Mm-hmm.
So you said 63 per site. Is that 63 until you get 63 people enrolled? Or there are 63 people that you're going to reach out to and...
It's until we get 63 people enrolled. Yeah, so we're going to end up reaching out to a lot more people than that.
So with the 63, if you have somebody that has started and then they end up they're doing really well and they no longer participate, you bring somebody else in to keep that, so that's it. 63 is the magic number.
63 is the magic number. And we know some of those people may end up dropping out at some point, and we've sort of accounted for that in our projections.
I just wanted to add something to the question that Mary just posed, which is something that will come up in the future training. So as Dr. Cooper said, if a patient achieves their goal within a designated time, they may decide, or you may collectively decide in partnership with the patient and the CHW that you don't need to continue following them. But we still want to follow them as part of the study. And so we would hope that you would be willing to help us ask them to still be involved, so still complete the surveys.
Is that going to be sent to the patients that you all will be seeing? We'll make sure that you all get a copy. But I'll bring the ones that we've already sent for the feasibility this afternoon.
Okay, yeah, that'll be good, because that'll give you an idea. It's probably gonna be pretty close to that one.
And I may be jumping ahead of things, but with HIPAA, are we gonna have a listing of who is involved with the HIPAA for the patient? So if we're doing a home visit or something, we'll be able to have access. And who's
Yes.
responsible for updating the HIPAA information in case it changes?
So, so we have what is called a HIPAA waiver in order to recruit people, and then once they are in the study, they have signed a consent to be in this project. So that means that all the members of our research team have the ability to get information about that patient. In terms of the patient's clinical care, that would be something that you would follow the procedures of the practice on, how they generally handle that piece. So can you give an example of what you might be
Well, I'm
concerned
not
about?
really assigned to any of the specific clinics that
Mhm.
are listed, so
Mhm.
I'll just work with the office managers in regards to the people that I'm working with, I guess, in regards to HIPAA, if I need to find out who's on HIPAA.
Yeah, I think so, but I think we'll be likely, as we move along and the project gets started, we'll be finding out more about which sites you're gonna be working with and what the policies are about that, But for the most part, you're gonna be interacting with the care manager the Rich Life Care Manager from this project, who's at whatever site you're going to, and with that patient's primary care provider. But anybody else who's involved in the care of that patient, like if it's a dietitian or a social worker or somebody that is involved in the care of that patient, you should be able to
Well,
talk
I'm
to that
talking
person.
about family members.
Oh, family. Okay,
Right.
so here's the thing. So we are going to get you, and we're going to get more into this later, but you're going to be able to record on a form who the patient wants you to be able to reach out to. And those are the people that you can, based on what the patient tells you, that you'll be able to contact if you need to find out something about the patient and where they are, or something like that.
Okay, wonderful. Thank you.
So maybe I made that more complicated than it needed to be. So these are the interventions again. So this is the first group, which is the group you're in, collaborative care intervention, again, delivered by nurse care managers. Most of the care managers are nurses. There may be some places where the care manager isn't a nurse. And then the care manager has the option at a certain point, and we'll talk about what that would look like, to what we call step the patient up. So like if they've been working with the patient for 3 months and they've been doing everything, within all of the clinical protocols, and the patient still isn't meeting goals, they can step them up to either a community health worker support or a subspecialist consultation. And we'll talk, more about what each of those are. So first, what is a collaborative care team? Have you all talked a lot about this in the work that you're doing? Okay, so everybody sort of has been talking a lot about this, moving from one person being responsible for taking care of a patient to a team being responsible. So this is a group of health professionals who are working together to improve the health of their patients. And so each member of the team has, this is not the updated slide, but anyway, but each member of the team has, uses individual skills and abilities to provide the highest level of care to their patients. So the simplest collaborative care team is just a primary care provider and the care manager. But we all know that there are many patients who require more than 2 people to manage help them manage their health. So at some practices, you'll have social workers, you'll have mental health care providers, you'll have pharmacists, you'll have dietitians, and in that case, all of those individuals are going to be thought of as part of the collaborative care team. And there are some practices where they don't have as many people, and so it's really just going to be the care manager and the primary care provider of that patient. So it just sort of depends on where you are as to how many people are going to be involved in caring for those patients, right? So, the idea behind this model is that basically, we empower providers by having a very proactive and supportive team. So it's not just the provider who's responsible for everything, but nurses play a role, community health workers, pharmacists. And then we also, the idea behind collaborative care means collaborate, right? Meaning that it's not something where the patient gets told to do 1, 2, 3, 4, 5. It's something where patients are really involved in setting the goals, in talking about what works for them, what doesn't work for them, and in contributing to the care plan. So the reason we're using this model is because it's been shown to improve health outcomes. It hasn't been used as much in this way, for example, not as much with underserved populations, and it hasn't been used with community health workers really being connected to the team. So there have been community health workers out there working with patients, but as far as really refining that process where the community health worker really gets integrated into the practice team, there hasn't been as much work on that. So we want to try to make sure that we do a great job of like refining that model and that role for the community health worker and the care manager sort of working together and being integrated into the practice team. So the objectives of the collaborative care team to develop individualized medical management plans and self-management goals for patients using a structured assessment, which I believe many of you are already using. Ours is very similar to what you're using. There may be some adaptations to that, and we'll show you through that as we walk through that. And then we're also, the idea behind this is to really monitor the patient's progress in attaining their goals by having planned follow-up contacts. And then to address all of their issues through treatment protocols. So we have treatment protocols that you can follow, and then to determine whether or not the patient needs additional support from a community health worker or from specialists. And then at that point to make that referral. Okay? So the stepped care piece is either community health workers or specialists, and the community health workers will support patients in reaching their goals by actually going out to the patient's homes if that's acceptable to the patient, or meeting them somewhere else in the community, and then actually basically helping them to address issues outside of the clinic that might be getting in the way of them reaching their health goals. Sometimes patients will not have so many social or psychosocial issues, but they might have a lot of medically complicated issues, and in that case, instead of stepping the patient up to a community health worker, the care manager may step them up to a specialist consultation service. And that's we have a specialist consultation group that's part of the project. And so we've engaged specialists in different areas, hypertension, diabetes, in psychiatrists we have a preventive cardiologist, we have a smoking cessation expert, and in that case, this care manager may recommend to the primary care provider that we get some advice or consultation from a specialist. So, and then the community health worker intervention, basically, again, to enhance and reinforce the patient's self-management behaviors, help them access care, address their psychosocial needs, promote the patient and family member communication with other health professionals, and activate the patient to participate in their care, focus on the patient's self-identified priorities, and then be integrated into the practice and part of the care team. So, and then the specialists, again, I already mentioned to you who they are, and so the care manager will then reach out to the primary care provider, suggest that we get a subspecialist consultation, and then make a referral to the specialist group. Okay? I know I'm sort of running over time here, right? I've been trying to engage everyone in conversation. So Dr. Marsteller is...
You will be getting all of these things, as Lisa just described, in the clinics where you're working. These will also be going on. So really, your intervention is on the top of these particular interventions, so that clinics that are in standard of care plus are only getting the things I'm talking about. They don't get the benefit of CHWs and care managers and collaborative care teams. And so they probably would wish they did, so don't tell them. So we'll start out by talking about what is kind of the base, And the base includes a health system leadership support intervention, hypertension dashboard, standardized BP measurement training, and then hypertension care best practices training. And so these are kind of the pillars of what the Standard of Care Plus is getting. And so it's meant to intervene on their clinical decision support system, right? And a little bit at the leadership level, leadership support, and then also providing support for the delivery of high quality care. But it's all clinic based, and it doesn't try to reach into the community the way that collaborative care much more reaches into the community and addresses things that people may be facing in the clinic or the community setting. So specifically, the health system leadership intervention includes face-to-face or web-based sessions that will feature brief didactic interactive sessions among the people who are leading the health systems that you belong to. So there are representatives from Johns Hopkins Healthcare and from Total Healthcare who come to these webinars, and they learn about both leadership issues and disparities and equity issues. And then they talk a lot about how to bring those two things together. How do we lead to promote health equity in our systems? And in fact, you guys are invited to join these webinar sessions if you would like to, and I'll show you the schedule on those in just a sec. And then they also will have an opportunity to interact with the people who are on the front line in the practices during coaching calls. And the coaching calls are the perfect time to say, hey, this isn't going well. You'll have a direct line to ask the system level champion for the project in your system during those coaching calls. So that's also very handy. So these will help them kind of understand a little bit more about health disparities and health equity. Topics and leadership are a focus here. Activating their roles as system level leaders. How do they go about leading, again, in these areas, and integrating health equity into the culture of health at their practice. All of their practices. So the webinars, these are sort of, again, these tend to have a little bit of didactic, a little bit of slides, and then they're much more focused on interactive discussions and other activities to try to engage everybody. So these will be held from 12 noon to 1 on Fridays that are listed there in September, and if you'll notice, it's quarterly, right? So these are just once every 3 months. There's a webinar on a Friday from 12 to 1, and again, you're invited to join us for these. There's also these coaching calls that I mentioned, and so the coaching calls are only for collaborative care and stepped care clinics, so only for your side of the intervention. And it's a direct line, again, to talk to the system level leader for your system. And also your practice champions will be there on that call as well. And it's a great way for the group to talk about, you know, hey, we're having this problem, or oh, this is going so well. Let us tell you what we're doing special in our clinic or our practice so that it gets shared across all of the other practices and clinics, and everybody can benefit. Yes?
Can you push these all out to our Outlook calendars?
Absolutely we can, yeah.
That way we have calling numbers and all.
Yeah, no, absolutely will do. So these then will be held on the fourth Thursdays from 12 to 1, and they're quarterly, they're monthly, but not in the months where there's a webinar. So if you've got a webinar a month, you don't, there's no expectation that you also have a coaching call. Yes?
Question, can those calls be recorded? Because some of us at times have our SAM meetings. It might interfere with those dates.
Okay.
Can they be recorded?
Yeah, and I think if we find out that there's a major problem with that time, then we'll try to find a different time. I mean, we'll try to work around it. But if everybody's in one meeting or something on that day, then obviously isn't going to work very well. Yes?
So tentatively, our first one isn't scheduled until October.
Okay.
No, I'm
Or
asking.
you're asking,
right
I'm
here.
sorry.
No,
I thought you were telling me about this
Oh,
meeting.
no, I'm sorry, I'm going back to the calls, because it says that the webinar is gonna be, the first one's held in September.
Mm-hmm.
So then October would be when we would have our first conference.
Coaching call. Well, that would be true, except that we already have had a few of these webinars. So we're already in the schedule for these webinars. We will have a coaching call that's coming up with Johns Hopkins Healthcare as soon as we're able to get that on the schedule. So far, we haven't been able to get it on the schedule, so that will, healthcare and JHCP will be joining the coaching call schedule soon. And it starts out with one call that's just for JHCP sites. Total Healthcare already had theirs. You may have heard about it from others who joined in the first coaching call for Total Healthcare. So the very first one is just one system at a time. Then the next one will be all the systems that are participating will be talking to each other, and then it'll roll out that way, where as systems come in, they get their own call and then they join in. Okay?
Thank you.
Yeah. All right. So there is also a practice level hypertension dashboard. And so the dashboard is going to be in both these standard of care sites and in collaborative care, step care, which is your arm of the intervention. The dashboard, as you note, tells at the provider level and at the practice level how the team is doing with respect to care for all hypertension patients, not just the ones that are enrolled in our program. It's across the board. How is division doing with all of their hypertension patients, right? And then it breaks it out by Black non-Hispanic, white non-Hispanic, and Hispanic patients. So what we unfortunately typically see is that for our African American and Hispanic patients, there tends to be a lower success rate in terms of control numbers as compared to whites. And that happens for almost all providers, and it almost always happens across practices. And that's one of our key goals, is to try to narrow the difference in control rates across the different populations. And so you'll see a dashboard that looks kind of like this, where there will be some color coding as to whether goals are being met, and the arrows will just let you know, is it better this quarter than it was last quarter, or is it worse this quarter than it was last quarter? And so these are really handy to try to keep track of how things are going. Hopefully they're going to also motivate some interest in figuring out, who am I not controlling from provider perspective, for example. Who is not controlled right now? Let's dig into our data and figure out who we need to address specifically. Right. Okay. In addition, there's a blood pressure measurement training, and so there are videos that the certified medical assistants are watching. In addition, there are trainers who have been trained, so there's a super user at each one of the different participating practices, and this is in both the standard of care and it's in your intervention arm as well. Down there at the bottom, you may recognize Joe Landavaso as the guinea pig or patient in this particular case, having his blood pressure measured. I think he did fine on his exam. And that's Tony Bunyasai, who is working with training the group. So there are clinical educators who are training and assessing certification and so on. And this is meant to standardize the level of accuracy of blood pressure measurement across all of the practices, regardless of what arm they're in. Okay?
So, Jill, I just wanted to make sure that they also know that you will be getting training in blood pressure measurement from our team as well. So you know those devices you see up there, the Omron devices, you'll be getting training in how to use those, and also in how to use the home blood pressure monitors and how to teach the patients and how to use those. So you'll be seeing a lot of the folks you see in the slide. And I think the MAs in the picture are from Total Healthcare.
Okay. You may recognize some people on there. Maybe that fuzzy blob over there. Oh, that's my friend, the fuzzy blob. I know that fuzzy blob well. So the Omron devices are great. They're accurate, and there is a protocol that goes along. They're easy to use, and in addition to that, the project has given these devices to all of the practices. So, you know, that's kind of a nice thing. They've all got a nice measurement device for measuring their blood pressure in their practice. And so, just real quick, you see the proper positioning is a key piece of making sure that we're getting an accurate measurement. And so we've tried to make it as simple and straightforward as possible so that people don't have any difficulties with compliance. Might be hardest thing is to keep the patient from jabbering on but they're supposed to be quiet. They're not supposed to cross their legs. Obviously, their arm has to be at the appropriate elevation. The cuff has to fit appropriately, and their feet are supported as well as their back when the measurement is taken. We try to make all of that training as easy and straightforward as possible. Then there's also, but I'm sorry, did you have a question?
Yes. All the measurements that are going to be considered for this initiative, will they be taken at the site?
Yes, that's right. And so right now, the training that I've been talking about has already happened in your site. So
we've been talking at you a lot. So what I want to do is just drill down a little bit more into your roles and responsibilities as care managers and community health workers. And I'm going to show you what we have in mind based on our knowledge of the research, like what really is effective, and then as well as based on input that we've gotten from patients, from community members, from health system leaders, all the people that were part of our advisory board. And so as you look at the roles and responsibilities, you can let me know whether this looks about right for what you do, and if there are issues that you see up there that are new or unfamiliar to you and you have questions about, feel free to raise them, okay? So we'll start with the care manager responsibilities. So the first group of responsibilities we've labeled under as patient change agent, right? So the first thing that we see the care managers doing is helping to identify any barriers that the patient may have to managing their cardiovascular risk factors. So that includes hypertension, of course, which is the primary focus of this project, but we are also interested in other cardiovascular risk factors. So things related to lifestyle, like diet and physical activity, and adherence to medications, smoking, all of those things. So identifying the barriers through that structured assessment, developing a plan with the patient and other members of the care team to reduce the patient and the system barriers to the patient getting optimal control of these risk factors. And then using motivational interviewing as well as behavioral activation skills with the patient to facilitate their progress. So, that sound familiar? Sound like stuff that you do? Okay. So patient change agent. The next role we see the care managers playing is as educator. So you will be identifying any patient misconceptions or any knowledge deficits they may have that might be impeding their successful management of their illness. You're also going to be working with the patient to develop a tailored education program. So we are going to have materials that you can use in your interactions with patients to help them get to the goals that they want to achieve. And then we will also have materials that you can use to help educate patients about specific issues where they may actually just not know, or they may have had a misunderstanding about their illness. So what we're hoping that you will do is to use your professional background to tailor that approach to where the patient is, to their literacy level, to their level of activation, all of those things. So you're going to use materials and methods that you deem to be appropriate, for that particular patient. And you'll have a variety of different resources that you can draw upon for that. The next thing we'd like you to do is to develop the patient's ability to effectively interact with these resources and then with their physician and with other resources in the practice. So we want you to help to empower the patient. So you're gonna assess their needs, find out where they are, offer them the resources they need, but then also encourage them to like advocate for themselves, right? So that's the educator role. And then another role is as a care facilitator. So what you'll do is to collaborate with the primary care provider and the other care team members on managing the patient's risk. So, you know, the provider may tell you that he has been concerned about the patient being able to take a certain medication, or patient not really being able to follow through on following a DASH diet, for example. And then in that case, you're going to be working with the provider and or the pharmacist or whoever is working with the patient to help to promote those goals. You're going to be continuously reviewing your panel of patients to identify any problems, and then discussing those patients with the providers. And then so we say at monthly meetings, but I think it's going to depend on the site. So there are some practices where there's actually a meeting of the providers where they might invite the care managers to come in and talk about specific patients or issues. There are many practices where there's not that type of a forum, where they prefer to have you just reach out to them informally and talk to them like in the hallway, or send them, actually you don't want to talk about patients in the hallway, but in an exam room. Or they want you to send them like a message through the electronic medical record, you know, to tell them about a specific situation. So we expect you to do that, to provide ongoing monitoring through if you follow the protocols, you'll see like how often you should be seeing the patient back to see how they're doing with, for example, their cholesterol level or their glucose level, as well as their blood pressure. You're going to have a system that you initiate and maintain to track the patient's risk factors. And then you're going to monitor the patient adherence to the treatment regimen, and that's through the structured, again, protocol for, you know, every time you see them back. You're going to monitor to see if they develop a new risk factor. So sometimes, you know, patients with uncontrolled hypertension might end up developing heart disease. So somebody may come in to see you and then tell you that they've been having more shortness of breath or chest pain when they're going about their daily activities, and in that case you would intervene and make sure that they get whatever care they need for that particular new risk factor. You're then also going to engage any additional resources you and the patient deem appropriate. So whether that means bringing in a family member or referring them to some resource in the community that they can use to help them achieve their goals.
You mentioned resources. Would that include maybe a digital scale if they are to that point where they need?
Certainly. You know, if they can.
And it's paid for?
Well, it's not paid for by the project, so they would have to be able to afford to purchase it, or you would have to work with them to figure out how they might be able to get one. Now, we do provide home blood pressure monitors for all the patients in this study.
Oh, that's good.
Yes, so that's going to be very, I think, a benefit, yeah.
How do the members get their blood pressure machine?
Okay, so that's where you come in.
Or are they going to be at the site so we can pick them up, or?
We're going to bring them to the sites,
Okay.
and then when the patient does their first intervention visit, and they go through their needs assessment with a care manager, the community health worker will be present for that, and then the community health worker will give them the device and teach them how to use it. And we're going to teach you how to do that so that you can do that. If you probably already know, but we'll do a refresher training.
Education materials, will the CMs have the ability to use other educational materials, or are you providing all educational materials and they should stick with the educational materials provided by you guys? Because currently they have educational resources that they use, Cranes and Emmy, which have videos at different literacy levels. Are they going to be able to use those, or should they just stick with the materials that we're providing?
So I think you should use resources that are available to you. What we'd like to do is we'd like to see some of those and hear about them so that everyone would, more people can have access to them. We will have some suggested materials that you use, but again, we're open to input from you about if you know of a particular resource that's really good for certain groups of patients, we'd like to hear about it and then share that with other care managers. Okay, so we do have a whole session that's on patient educational materials, so. Let's see, now we're on to the community health worker responsibilities. So community health worker responsibilities, again, they're gonna have an educator role. So you're gonna reinforce the education that the patient has already gotten from the care manager about disease self-management, right? You're gonna reinforce whatever education they've gotten on hypertension and on their other health conditions. Okay, so we'll have a lot, again, like I said, a lot of the materials available to you that you can use for each of these conditions. We will encourage you to use those materials. If you have others, again, we'd love to hear about them.
Is there going to be an application that we're using specifically for these members? Or where are we inputting notes and where can we look at notes to see what resources
Very
have been
good
shared?
question. So, it's very important that you document your interactions with the patients in the electronic medical record. But because we haven't been able to integrate our system into the electronic medical record for each system that we're working with, at least we haven't so far, we've set up a system where you can document in REDCap. So we're going to teach you how to use that. It shouldn't be that hard. We're providing laptops for those of you who don't have them. For people who already have laptops on them, we will make sure that you have access to REDCap on your laptop. And then, so everything will be captured in that system, and then you can take that form and you can upload that to the electronic medical record. And that could be most of what your note is, but you may have like a brief note that says, here were the patient's goals, this is what I addressed, this is what we discussed, and these were the action plans we made. And then you can also upload your REDCap assessment.
So whatever system that REDCap note is uploaded to, that's where the note's going to be?
Yes.
So if somebody is in PopDB and we don't have access to PopDB and they upload the PopDB, we're not going to be able to see it. That's something within JHC. If it's Epic, it's one thing.
Well, no,
If it's JCare, it's something else.
Right, but it's going to be Epic, is my understanding, is where you're going to upload your
If the
REDCap.
member is in Epic, but
Yeah.
not all members are in Epic.
Why aren't all members in Epic?
They're already talking JHCP sites, so
Yeah.
they should all be in
They should all be in Epic?
Yeah.
All
This
right.
is JHCP. Yeah.
How about for, total healthcare, we have a thing that we don't have Epic.
Yeah, it doesn't matter, so you can upload your REDCap form to Athena as well.
Okay.
Yeah.
Are the case managers gonna be expected to document in Epic and REDCap? Is that the expectation for the case managers?
Well, we don't want you to duplicate anything, okay? So what we're hoping is that what you do in REDCap will, for the most part, be your note. You know what I mean? I think that there may be some minimal thing that you need to type up at the beginning to say, this is my, care management visit with like X patient or something like that. But then for the most part, it's going to be this note that you've uploaded that has the full assessment on it. Like I said, I think we're going to get to this in the documentation session that we have, but we're looking at something like putting like, these are the patient's goals, this is what we discussed, and here were the actions taken, and then upload the form, So it could be something like, we could work on creating some sort of a quick text template that you all use, but it's not gonna be where you have to do the full, like, JHHC assessment and then do ours too, because they're pretty much, they're almost the same thing.
So are you saying that what we do now in Epic as far as when we pick up a new patient, as far as the assessments, the goals, the care planning, you're saying that's all gonna be in this REDCap? and then we're.
That's what we're saying essentially, because we had hoped to have our questions added to what you're already doing, because we have a few additional questions, I believe. But we haven't been able to get that all done in time for the launching of the project. Now, that's something we're still discussing, and it may be that we come back to you before July 1st and say, we were able to do it, so all you have to do is just use your care management, like, assessment template, you know? But so far, we haven't been able to get that done.
So while we're on this topic, I just figured I should ask. So you said the 63 patients will be identified for each clinic. So the case manager who's there is going to be essentially responsible for the 63 cases. And just to clarify, the insurance can be Care First, can be whatever,
Yes.
Medicare or anything.
Yes.
So what's the level of involvement for the case manager? And I ask because you're going to have your 63 caseload, but then you have your 85 under your regular case management.
Yeah.
What?
So there, it is, you know, the involvement is when the person comes in, you see them, you do a 1-week follow-up, and it's generally, we're gonna say like a bi-weekly follow-up. Now, here's the thing, it could be that some of these people are people that would have come to you anyway, because they've got a number of medical issues that are uncontrolled. So I don't know that, it's possible that some of the people that you get through us were people that were going to come to you anyway.
But what happens is, even though they were going to come to us, we're still gonna get whoever else. The fact that they were going to come to us does not negate the fact that we'll still get others. So
yeah.
they're not counted in the number
Yeah.
that we will end up getting the regular, you know. the
Well,
others.
no, they are counted. Now, I guess what you're saying is, are you responsible for a specific line of business? Is that?
We're responsible for specific lines of business and X number of cases.
Mhm.
So say Priority Partners and Medicare up to 85 patients.
Mhm.
So that's your everyday,
Okay.
what you take care of. And then there's this, so you're going to have 63.
Right. I guess what I'm saying to you is that it's possible that it'll be 85 plus 68, but I think it's going to be something between that. I think that the patients we get are gonna be Medicare and Priority Partners too.
Right. But they will not, if you have them under Rich Life,
No,
they can't be in.
Can
Can they be in both?
I
Can be in
think
both?
they can, yes.
They just
Okay.
can't start.
Yes,
just
they
can't
can
start
have been already in your
Okay.
panel and then come into
And then
Rich
come
Life.
in.
But if they're new, they could, when they come into Rich Life, they are
can.
also part of your
Okay.
panel, yeah.
The other thing I wanted to add too, I think this is a really helpful discussion, just thinking about the realities of the workload that you're going to have. And we really tried to be sensitive to that, so we've had a lot of discussions with Regina, with Cassie, with Linda, to talk through the logistics around what would it actually look like for you to take care of Rich Life patients on top of the ones that you have. So I just want to put out there that we are thinking about this and we're working with the people who kind of have like jurisdiction over determining this so that it's not burdensome to you. So
Yeah.
that's something that I wanted to add as well, that it kind of goes back to what Dr. Cooper said earlier, and I think Dr. Marsteller probably touched on it too, about this whole idea of working on it jointly so that we know and are attentive to what you need and we're responsive in terms of figuring out what actually is feasible. So I wanted to put that out there.
Thank you, Chidma. Yeah, because one of the other things we've talked about is really carefully monitoring like the caseloads.
Because we
And
want,
then deciding at what point maybe new staff might need to be added, you know, so that the current staff don't get overburdened. So that's one of the things we've talked about is like, we're gonna be looking to see whether it looks like the caseload of certain care managers is getting up to the like upper limit, and then it's like, okay, we're probably gonna need to hire a new staff member, you know.
Demographics for the patients, are they strictly Maryland residents, or do they go outside? Let's say Pennsylvania,
Yeah.
West Virginia.
It doesn't matter where they live, as long as they are getting care at that particular practice and they have these conditions
The reason being is that if a patient is outside of Maryland, then there are only a few case managers that are able to manage Pennsylvania, not West Virginia, but Pennsylvania patients. So
Because
it's
of,
limited, right, because of the license.
okay.
You have to have a separate license for Pennsylvania.
Okay. Well, I think it would be helpful to us before the end of this training to know who's licensed to do that. And because that will give us an idea of whether we ought to limit the eligibility to people who are from Maryland for this, for JHCP anyway, because we do have practices in Pennsylvania, you know, that, and so we can't say that the patient can't be a resident of Pennsylvania to get into the study, but we could say that if they are getting care at JHCP, that they need to be a resident of Maryland. So we
Right.
need to kind of know, if you guys can let us know by the end of, maybe we'll put in create like some sort of a document where you can let us know if you're licensed to care for patients who are in Pennsylvania or West Virginia.
Right. If we have that situation now.
Okay.
going on.
Great questions, okay.
For the CHWs and home visits, are, for reimbursement purposes, is there a different reimbursement procedure that we're gonna follow? Does it get charged to the grant, or is it, do we just do ours?
Extra for being part of the program, because at least for now, it's a research, it's already being paid for by research, so we shouldn't be double charging for it.
So I think what she's asking, the CHWs currently get reimbursed from JHHC for the mileage they use through a reimbursement process that we have at JHHC. So what she's wondering is that reimbursement
So mileage,
process,
okay, so
right,
that's
for
like
her
a,
mileage.
yeah. So the project will cover mileage.
Right, we have mileage budgeted. We've tried to balance like to each of the clinics based on, you know, like, are your patients drawn from close by or further away? So we've tried to balance that out so that, you know, we spread that money equitably on that. So we do have an upper mileage cap, unfortunately, that each person will have, but it's gonna be based on where you are and if you're dealing with rural patients or not. In terms of like how we actually reimburse you, I hadn't thought about that question, but we will find that out. Just know that there is money for it, and whether you guys send that to us or send it to your normal way
JHHC,
of
because
doing it,
what we
we're
may
gonna
do
work
is
that out.
put it in the subcontract to JHHC, in which case you would just do what you normally do.
And then for postage, we just go ahead and mail it out from the office, and then the office will take care of postage for any educational materials that we might have to send out to the patients, or any resource materials that we send out to the patients.
That is one that we didn't realize, that you normally do things by mail, but we can take a look into that and we'll figure that out as to what the normal process for
Yeah,
that
the
would
ones
be.
that have email access and are wonderful about receiving it via email, then that's fine, but it's just some of the older people, like with Medicare, they just don't have the email capability,
I get
so.
phone calls from my mom.
I know.
So I understand. We'll look into it. Can you give me an idea, just, and I know it's rough, but like ballpark, is that 10% of your patients? Is that 40% of your patients?
It varies in regards to the patient load, because we get Medicare, we get priority partners, you'll get
Okay.
people in priority partners who don't have access to computers. So, I mean, it really varies. Most of mine would rather have me mail it out than to send it to them electronically, because they don't have the capability either to pick it up in email or to print it.
Okay. All right, we will figure something out and we'll let you know.
Okay, great, thanks.
Can these patients be involved in the home healthcare agency?
Well, yeah, I think that, people are gonna get into the study based on what we ask them. So if they are in the study and then you find out they're involved in home health, I mean, I think some of the questions that we ask hopefully will weed out people who are already getting lots of services. If they get into the study and they have home health, you may decide that you don't need to step them up to a community health worker. You may decide that you will just work with whoever is working with them on the home health side, So a lot of it is gonna be up to like your clinical judgment, And like I said, we're gonna have monthly, I think our meetings with you are monthly. where you can bring up specific cases or questions like, I'm not really sure what to do about this particular situation, what should I do, you know? And then we also have a primary contact person for you for the research team, and in your brochure, I believe it's Katie Dietz.
Katie for the care managers
And Chittima for the community health workers, so that if something comes up and you don't know how to address it, and you don't want to wait until the next meeting, you could send them an email. But, you know, ideally, if it's not like urgent, we like it to be discussed in the meeting, because that way, if somebody else is facing a similar situation, then everyone has the benefit of like hearing about that.
So I'm currently a program manager at JHC, and I can tell you that our case managers currently are hovering around 45 as a caseload now. So only few, maybe more for you guys. I'm speaking on my team. So there are going to be few case managers who can take another 65. So just put that out there that hiring new staff probably is going to be more imminent than what is perceived, because I know.
We already have 60 to 80.
Right.
Yeah.
In some regions, they're already at 65 and close to 80. So that's something we should be thinking about now, because it's going to be highly unlikely that any case manager in here today can take a 65. So we'll just keep that open on the table, because I know the case manager's case
Right.
loads.
No, I hear
very
you.
well,
I
so-
hear you. We appreciate that direct feedback from somebody who's on the ground,
Right.
you know.
I don't know if you're gonna get to this, but can you just give us a snapshot of the interventions? Quite often, there's a lot in the beginning, but as the 2 years roll around, you know, is it every 4 months,
You know, yeah, so
What is
we're
it?
definitely going to get drilled down to that in a lot of detail,
Okay.
so.
I'll look
Again, like I said, a lot of it has to do, I think it is, you're right, a lot of it is the upfront kind of getting to know the
Yeah.
person and figuring out where they are, and then the rest of it is sort of checking in periodically to see where patients are and
Right.
whether they need anything more. And a lot of that is not even necessarily done in person unless unless it's really needed or preferred.
Hi, I'm Denise. So we're just talking on the phone, so we're from Total Healthcare. So we have about 6 sites. So from Total Healthcare, can you tell us how many patients at each of the 6 sites have been slated to go into the Rich Life program?
It's only 3 sites that's
3
gonna
sites.
be the collaborative for
Okay.
the program. So it's gonna be 63 patients from each one of those sites.
Okay, thank you.
All right, thanks. Yay. All right, so we're here to work with you guys, okay? I mean, we all, in order to be successful, it doesn't help me if you all are like overburdened and can't manage what I'm saying, because I'm gonna look bad, really bad if that happens. So we've gotta do this all together. No, seriously, I have to defend this project to the federal government, okay? So I can't do stuff that like makes everybody crazy.
Just a question about the number of encounters. Is it semi-annually, so like once every 6 months per patient that's enrolled, or is it more frequent encounters with these patients?
So I think it's more frequent like at the beginning, like I said, until people get on track. You know, we were saying bi-weekly, but it could be that people say, you know what, I don't have time to talk to you every 2 weeks. Please don't call me until next month, you know, and then, you know, so again, this is not going to be one of those things where you have to do it because Rich Life said you have to take my call. No. Okay. All right, so I think one more, I mean, I think I'm getting the idea that you guys know what we're talking about here. So I don't know that I need to even go through the rest of the slides,
But as far as patients coming to us, are they identified through, like in our case, population health, or are they rolled out through another
They're identified through like our system, but again, it's really not our system. It's through JHCP data, and again, we're working very closely with JHHC to see to what extent the people we identify actually overlap with people that they would have identified as needing care management anyway, you know?
I'm just wondering, is there going to be some type of flag? So we'll know, is this a regular patient that we're receiving, or is this a Rich Life, like something?
We're going to tell you, our Rich Life team will reach out to you to say, this patient is a Rich Life patient, you know?
Okay.
One last question about documentation. You said that the documentation for the 65 will be somewhere around bi-weekly in red cap. So currently, JHCP site CMs document in Epic. And they document everything that Rich Life would want to see in red cap. So avoiding double documentation doesn't seem possible to me as a program manager, because you want this information in red cap, and they are gonna document in Epic regardless. So are you gonna say that for these 65 do not document in Epic and only document in red cap? Or are you gonna?
So, you know what? Can you allow us to like talk with Karen about this, exactly how we are gonna deal with this?
Yeah.
Because the reason we came up with our red cap system was because we thought that we weren't going to be able to use the Epic system. So it may be that we come to an agreement that you guys are only gonna use red cap for this. And that you're going to, the way you're gonna make sure it gets into Epic is that you're going to just upload that form. Or we may come to an agreement that we're just gonna use the system that you have. So, but can you give us a little bit more time to like really get that figured out?
I don't know if I'm jumping ahead or not, but the incentives for the patients, is there like a maximum amount that folks can get within the 2 years?
Yes, it is, and I forget exactly how much it is, but it's $25 for 3 interviews, so that's $75, and then 2 $10, right? So that's $95.
Okay.
Plus your patients will get the home BP monitor, which is worth about 70.
Okay.
And they'll also get a tote bag and to carry to bring to you guys to see, and you know, in health case that's appropriate for that.
Co-pays on their visits, will those be waived?
So.
Ask them to
Yeah.
come in more often than
Right.
they normally would.
Right, no, I know what you mean. So we're gonna definitely go through the Hopkins system, which does not allow us to bill for research visits.
Okay, completely.
Yeah.
Okay. Well, then that's, you know, that incentivizes them to be compliant with us.
It does.
Yeah. But these are great questions, which we dealt with before in a previous project, and for some reason they didn't come up again during this one, so I'm glad you brought that up. So I think we're probably out of time, because this is all about the community health workers making, you know, that they're serving as educators, they're enhancing access to care and addressing barriers to care, making referrals as appropriate to community resources, serving as a facilitator and a navigator to social services as well as clinical and other services, and then supporting patient adherence and communication with their providers. And then I think that's it. So again, thank you for your engagement and enthusiasm and all of your wisdom. And again, we just want to encourage communication, openness, transparency among us, trust, and respect. We have a lot of respect for you and your experience, and we just are so happy to have you joining our team. And you'll hopefully be in the photo with us in our next presentation. So, and I think we've had a lot of questions, so I'm going to, unless anybody has burning questions, I'll let the next person come up, and I'll turn over to Chidama.
Hi, everyone.